There is a paradox. In America, we're told that it's the fast-track gay and the intravenous drug user most susceptible to developing AIDS. In Africa, we're told that it is the heterosexual that is most susceptible to developing AIDS. Why the contradiction? Well, we haven't looked carefully at the facts. We've been told numbers ranging from 5 million to 25 million Africans have HIV and that there's going to be an enormous amount of death. But when you actually go to Africa and you interview the physicians working there, you find that these are presumptive diagnoses.
One of the things that is important to emphasize from the outset is that the definition of an AIDS case on the African continent differs decisively from what constitutes an AIDS case, say, in North America or Western Europe. A definition was arrived at as a result of a World Health Organization sponsored conference in October of 1985. What resulted was what's known as the Bangui definition. The Bangui definition of an AIDS case in Africa is based on 4 clinical symptoms. The clinical symptoms are a high fever, a persistent cough, loose stools for 30 days, and a 10% loss of body weight over a 2-month period. By that definition, a Western researcher like myself has had AIDS. But having gotten on a plane and flown back to California, I'm not considered, of course, an AIDS case. So I think it's important to keep that in mind whenever one looks at the data, the epidemiological data, about what exactly we're counting when it comes to AIDS in Africa.
And tuberculosis is for all intensive purposes, the AIDS disease in Africa is tuberculosis. So what the HIV theory of AIDS is actually asking us to accept is that sometime in the early 1980s, all the traditional causes of these diseases, especially the infectious diseases, the dysenteries, the malarias, the tuberculosis, which are, let's face it, a symptom of poverty, of poor sanitation, lack of immunisation, lack of medical services, hunger, starvation, were in fact replaced by HIV as the cause of all these diseases. I mean, this is not, to our view, this is not a likely scenario.
Where there have been good research reports, it's clear that these HIV tests render a ludicrously high rate of false positives when those tests are done among populations that already suffer from other kinds of endemic diseases, parasitic infections, and malnutrition. There was a study in the Journal of Infectious Diseases in 1994, for example, that made it quite clear that when they did these HIV tests on a population in Zaire, where there was widespread tuberculosis and leprosy, that the test results in 70% of the cases were false positive. If the test results are 2 or 3% false positive, a test is basically invalid. It's useless in terms of epidemiology. Now, what exactly they would be testing positive for is another question entirely. However, the numbers of AIDS cases are run together with projections of HIV seroprevalence or HIV infection. Usually these tests are conducted at a sexually transmitted disease clinic. Maybe 100 or 200 people are tested, or they're done at an antenatal clinic where pregnant women are also tested. And from those samples, then projections are made about the rate of HIV and the rate of HIV/AIDS, which are run together customarily in Africa. Not only HIV/AIDS for an entire country, but projections can be made, as they were made at the AIDS conference in Geneva in 1998, projections can then be made for an entire continent of 650 million people.
All over the world, entire nations are claiming that we also have an epidemic of AIDS. In India, especially in Bombay and Calcutta, in Thailand, in China, in Haiti, Guatemala, Brazil. Therefore, the idea of giving medications to everyone in a country doesn't seem reasonable. What would seem more reasonable is to give these people the type of infrastructure of clean water, proper medicines, good, healthy diet, and de-stressing them from the political conflicts and gross poverty so that they have some optimism and a built immune system to look forward to a future. That is not being done.
What they are finding is the poly-specific antibodies that are normally in people in Asia and Africa because the social conditions there. So they have been exposed to many parasites, so they have to have a lot of poly-specific antibodies in the blood, and that's what they are measuring in the ELISA and Western blot tests.
These are the classic symptoms of urban crowding, of poverty, of malnutrition, and of underdevelopment, which in fact afflict men and women fairly equally across the African continent. However, the value of Africa and this notion about a heterosexual epidemic of AIDS in Africa, I think was extremely important by the middle of the 1980s because it helped to shift the focus and helped to shift media interest to suggest that, well, while AIDS cases initially may have been confined to a small cohort of urban gay